Okay, so we're going to go ahead and start. So yeah, my name is Yosha Singh. I'm a third-year medical student here at UT Austin Del Med, and I'm really excited to start kick off our spring seminar series, Health Insurance and Organizing. This is our very first lecture, Intro to Health Insurance and Organizing. And if you could please sign in, that would be so helpful to me. No matter what background you're from, whether you're from UT or not. So I just want to start by giving a quick shout out and gratitude to every single person named above. They all had some role to play in this specific session, and in each session you'll see all the players who helped. But in terms of speakers today, the first half of the lecture will be given by me, Yosha Singh, and the second half will be given by Dr. Ed Weisbart. He is a family-trained physician. He's an assistant professor at WashU St. Louis, and he's also the Missouri chapter president for the Physicians for a National Health Plan. He's given like 700 of these talks to students, Rotary clubs, wherever, and he's really open for questions. And so I ask that if any of y'all have any questions, or any of the Zoom members, if you have any questions, please hold them, either put them in the chat or just write them down or something, because we'll have a designated Q&A period at the end of this. This is another reminder to please sign in. Okay, and so to start, I'm going to start by just defining some terms. And so I pretty intentionally call the U.S. Health insurance kind of sphere a non-system versus a system. So we'll start by defining what is universal health care. Universal health care is not any one system. It is a metric, an objective, or a goal. And what it means is to have all, or like 99%, very close to all, residents within a country have health insurance coverage. So it's not that when you say, oh, we want universal health coverage, that doesn't necessarily mean one system towards it, but it does mean a very particular metric. And as some of you may know or may not know, in interfacing our current health system, the U.S. is the only Western industrialized nation in the entire world that does not have universal health coverage. I will say that one more time. We are the only Western industrialized nation in the entire world that does not have universal health coverage. So by default in the United States, we are uninsured. There is no constitutional right to healthcare in the United States. And so by function of that, you either have a group that you are either by default uninsured, or there is some group that is, for whatever reason, advocating for you to have health insurance coverage within a particular pool of patients, or pool of people, rather. So when I say system, a system can get you universal health care, which is that objective. Like I mentioned, that's not only one formulation. So there's the Canadian formulation, which most approximate our Medicare system. There is the UK NHS system, which most approximate the Veterans Affairs health insurance coverage in the United States. Or there's the German Bismarck model, which most approximates Medicare Advantage. But this is just to say that there are different formulations of funding and administration that can get you to that goal. Another thing that's kind of hard in the health policy realm is to compare countries against one another. This is true for other kinds of global health or global policy areas as well. Just because you're comparing apples to bananas or apples to oranges, where there's different demographics, different needs, different resources. But one thing that I like to point out is that we have been talking about health reform in the United States for like over 6 or 7 decades at this point. So what I like to point to here is this dating back to 1990, which at this point is 30 years ago, 30-some years ago. In terms of minor changes, fundamental changes, a complete rebuild of a system are like its 3 kind of areas that were told for regular lay people in the country. And it is consistently true that in the United States, the majority of people rank fundamental changes or complete rebuild in comparison to other countries that, just like any system, have some level of disadvantage or some level of needing for reform. But by and large, you'll find that people do not talk about a complete rebuild for a system. They talk about minor changes that are needed. And we'll kind of get into that throughout the rest of this series. And so, with that being said, I pretty intentionally use the word non-system in the United States because, like I mentioned, by default, most people in the United States do not, or by default, in the United States, you don't have health insurance. So why even talk about any of this? What is the point of this organizing series that I'm doing? What is the point of talking about whether or not there's a constitutional right to healthcare? I want to point you to this one study. So the point is that basically they compared the association between a constitutional right and reproductive health outcomes among 157 countries and found that the introduction of the right to health is associated with a reduction in neonatal and infant mortality rates for all levels of democratic governance. So there were kind of two measures. One is whether or not there's some type of introduction to a health right, and the other was the idea of how democratic, quote unquote, a country is. And this finds that no matter what level you are at, even just having that right, even just instituting that from the get-go, the intention leads to better like health outcomes for infants. This is not true for maternal mortality, which again, stay for lecture 4, and you will keep talking about the nuances of this. But the other element here is that a high level of democracy doubled that effect of the better health outcome. So by default, introducing the right helps health outcomes, but when there's more democracy involved, that increases the level of good health outcomes that you can see. And so while a good chunk of this series is about health insurance and kind of empowering you all with the statistics and the evidence base that you want and deserve and get to know about how our health non-system functions, the other part is kind of investigating a little bit what is power, what is democracy, what is governance. And so something that I hear a lot from other med school folks, at least in my experience, and some of the others here sitting here, is the idea that people feel that they don't know enough to hold a position. That might not be true for you specifically, but just at large, this is something that I've heard. The idea that like, oh, I don't know enough whether or not to advocate for this or for that, or maybe I know something about that, I don't really feel like I'm the one who can do the advocacy. So I'll just look on the sidelines and see what other people are doing, and then maybe get some commentary on Twitter.com. The point of this is to talk about what horizontal power and how you can leverage horizontal power to influence decisions. So sometimes one formulation of power is the idea of all of you coming together to vote for an official, and then that official holds the gatekeeping power to be like, we're going to do this, we're going to do that. That's one formulation that we're very familiar with, but I want to empower all of you with the idea of horizontal power and community organizing, which in short, we're very briefly going over this today, but we'll keep going over it in the other lecture series, is the idea that when people come together in solidarity for a common goal that benefits the entire group, that's when you win. That is when you actually influence the decision. When you text about it or tweet about it or think about it, maybe you don't have the power at that point to influence the decision, but when you all come together and find out who are the people who have that gatekeeping power to give me the health need or the whatever that I need, that's when you're able to leverage that power and create a decision and feel less disempowered, or feel less like at the whim of a system. Instead, you can influence the system. I also want to start with debunking some myths. I want to shout out one of my friends in the group who reminded me of this tweet. But when we talk about health insurance in general, whatever level of knowledge that we feel like we have right now, I want to position and anchor that in the level of misinformation that tends to be, that has basically dominated the public arena up until kind of recently through this guy. So this is Wendell Potter. He is the former Cigna Vice President of Communications, something. So basically, like formal speak for he was the PR guy for Cigna. He is now one of the staunchest advocates for Medicare for all and universal health coverage. Annually, he shows up to the Physicians for a National Health Plan and Students for a National Health Plan convention to, and this is his words, not mine, talk about the lies, deceit, and the kind of like, just basically like public level of misinformation that he and other insurance company individuals have put out there to kind of obfuscate to us what is actually happening in health insurance. And so, basically here, I'll just read this really quick. Amid America's COVID-19 disaster, I must complain about a lie spread as a health insurance executive. We spent big money to push the idea that Canada's single-payer system was awful and the US system was much better. It was a lie, and the nation's COVID responses prove it. The truth? Here's the truth. Our industry, PR, and lobbying group, AHIP, supplied my colleagues and me with cherry-picked data and anecdotes to make people think Canadians wait endlessly for their care. It's a lie, and I'll always regret the disservice I did to folks on both sides of the border. Which, by the way, we can go into the nuance of what it means to be a health insurance executive individual who profited off of lying for years and years and years, and then now coming to make you confidence by coming to conventions and being like, hey, I'm a paid speaker. Let me tell you about why I support universal health care. But we don't want to talk about that today. The event we hear is that in Canada, no one gets turned away from doctors due to a lack of funds. In America, exorbitant bills are a defining feature of the system. What about quality of care? When it comes to COVID-19, there have been 21 deaths per 100,000 capita in Canada versus 34 in the US. So that's just kind of some context. Now, this is our series, so you're here for the first one. I'm just kind of putting this up here because these are all the dates, and if you need kind of a PDF or whatever to make it more accessible for you, all these are available online as well. These are technically the learning objectives that we're going over today, but just at large, the three main concepts that I want you to take away are number one, the cost of our health system. So how much we in the United States end up paying individually and also as a system at large, what the cost is. Number two, just the spread kind of like what is Medicare, what is Medicaid, what is private health insurance. And then third, which is what Dr. Ed Weisbart, an expert, will speak about, is what is single payer healthcare? What does that mean? So those are the three kind of things. So I'm going to start by, this is actually a little bit old, this is from 2019, but if the United States health system were to be a country, it would be the 5th biggest country in the entire world. In 2019, we spent $3.7 trillion on healthcare spending. In 2022, we spent $4.3 trillion. Now, maybe that would make sense if we were the best health system in the world. If we had the best outcomes, everything was just awesome, everyone was just living to 1,000 years old. No. I'm just gonna let y'all read that for a second. And just for context, this is the Commonwealth Fund. They're a institution that compares basically health policy, or like there's a lot of analysis for health policy and also comparative systems analysis. Right here, they rank 11 countries, the Organization of Cooperative Economic Development, OECD, please fact check me on that. But they compare high income countries basically who are more likely to compare than, like, let's say the US and India or the US and China, where there's different things, different metrics that end up making that comparison a little bit harder. Here you can see the US is at the very bottom. When they were doing average analyses, like, oh, the median this, the median that, they had to take out the United States because it was such an outlier in the data. That is how atrociously bad we are relative to other countries. Next. So no, again, we are not doing better just because we spend more. In fact, we spend $1 trillion more than can be explained by just our wealth, let alone our health outcomes. And finally, just to kind of, drive that point home, we have among 11 countries, highest infant mortality rate, lowest life expectancy at age 60. The rate of preventable mortality is more than double the best performing country, Switzerland. We have the worst maternal mortality statistics, more than twice than the next highest on that list of maternal mortality. And we have the highest level of avoidable death. And if you see on that chart, there's not a variance to that. It is pretty solid. We have the highest level of avoidable deaths in the United States. So the US ranks last among 17 peer countries in age group specific mortality rates. That is until Medicare kicks in. So what is it about Medicare kicking in where suddenly we're doing fine? Suddenly we rank well among other peer nations. And depending on where you come from and how much you know about health insurance, what you'll learn to understand is that Medicare is the only public national health insurance program in the United States that's federally funded and federally run. And it is the one that kicks in at 65. So Medicare is for the 65 and older plus like certain health diseases that are terminal. That's Medicare. So I'm going to start also by asking everyone, or actually I'll start, yes, by telling everyone, what is insurance? So insurance is the idea of risk pooling, right? And so the idea is that when something catastrophic happens, you want to be able to account for that. And you don't know who it's going to happen to, you don't know when it's going to happen, but you know that you'll have to pay a lot. So let's say there's some disaster and it's going to cost $100, and there's 10 people and they're like, oh, what if this happens to us? So 10 people pool in $10, and they have that $100 insurance bucket for in case something happens. Adverse selection is what happens when people opt out because they have different levels of information. So this can get a full course. I got a course on this when I was getting my MPH and health policy about what is insurance and what are all the nuances and what is specific about health insurance that's different than, let's say, car insurance or other types of insurance. But what I just want to end with, or like briefly talk about, is the idea that because, if you go to the next slide, one phenomenon within health at large is the idea that it's the sickest people who are driving spending. It's not overuse. It's not the idea that if I can have insurance, then I'll go and I'll get more care than I need. It's the idea that the top 1% of people with the highest health spending, meaning that they are the ones getting medical care, they represent almost a fifth of all spending. So 50% of the population is worth 97% of health costs. And the bottom 50% are only worth 3%. And who is comprised of that bottom 50%? Young and healthy people who do not go see the doctor. I never see the doctor. I grew up without health insurance, so I literally never go to the doctor. I am in medical school right now, and I'm constantly told to go get my physical or whatever. I get my house. But anyways, but it's not the idea. So people who basically don't need to help use the health system in our system right, or in our non-system right now, have the opportunity for adverse selection to opt out. And who does that leave? Who does that leave when young people and healthy people opt out? It's the sickest people, the people who are using health services, who now, rather than spending $10, are on GoFundMe on your Twitter feed asking people to please, please, please pay for my cancer treatment because my Medicare Advantage plan won't do that. So, like I said, we are a non-system, and I'll just kind of really briefly go through this. So sorry to people who do not do my kids. But yeah, so like I said, by default, we do not have insurance. The first biggest portion of insurers includes the private health insurance market, or employer-based health insurance. So 54% of our population, or 66% of all covered lives, so 2/3 of all people who are insured have private health insurance. And what they do is essentially the firm itself sets a payment policy and a benefit design with the insurer, and prices are set via bilateral negotiations between the insurance provider, whether that's Cigna, Blue Cross Blue Shield, Aetna, whatever, and the providers themselves. Now, this is kind of funky language. I feel like sometimes people talk, at least at the beginning, when people talk to me like this, I was like, what are you saying, insured provider? And so this is what I think is a kind of more solid, less abstract point, is the idea that right now, through our private health insurance model, we have a flat or regressive tax. So currently, when you get employed, you'll have your little paycheck, you'll have your salary, and you being taxed, a little portion of your salary goes towards your insurance. And so let's say you're a secretary and you're earning $50,000 a year, and you are one of those lucky people who has private health insurance because you happen to be a full-time employee, all the other things, because there are other kind of metrics that stop you from getting employer-based health insurance. And you have this insurance plan that costs around $15,000 a year, which is frankly a little less, a little more like, I mean, it's the range like 12,000 to around 18,000, but it's basically a car a year is how much you pay for health insurance. So if you earn $50,000, you actually, as a secretary, technically your labor is being compensated at $65,000. But your business is taking away $15,000 from you to pay for your health insurance. Now, maybe you look at that and you think, okay, well, yeah, but they're paying for my health insurance, that's fine. The executive at that same company is also paying $15,000 for their healthcare. Everybody, there's a flat premium that you're paying within your company. And so this is a flat tax versus, where is this? Okay. Versus, and Dr. Weisbart will get into this more, but there is many studies basically that show that single payer with increased income for the bottom 95% of our population because we would fund it through a progressive income tax. So rather than the flat tax that we see right now, where a person could be compensated $65,000, only given $50,000, while her or his CEO or their CEO makes, so much more and still pays the same rate, this would be a progressive income tax. Now, I only have a little bit left before I want to get Dr. Weisbart on the call. So I'm just going to quickly run through some slides here. One is that there are 30 plus studies by the Congressional Budget Office 30 plus studies, including 2 from the Congressional Budget Office, that show that single payer would save us money. There are plenty of resources here, which, by the way, please sign in and give me your email. I will give you these resources afterwards. But the rest of this is that Medicaid is another technically public program, but it is state-based. So while Medicare is federally funded and federally administered, in terms of Medicaid, if you've seen one state's Medicaid program, you've seen one state's Medicaid program. Texas is different than Oklahoma, it's different than Nebraska, it's different than Kentucky. And so that's just kind of one of the parts to consider. And so who has Medicaid? Over 74 million low-income children or low-income Americans. This includes the Children's Health Insurance Program. Also, while you are pregnant, you can be covered by Medicaid. This does not mean that after you will be covered. It depends on the state, but some states allow for after 2 months, 6 months, 9 months, but it is possible for you to be a single mother of a 9-month child and not have insurance. We see that at the hospital at all the time. Also, there are narrow networks. So while Medicaid is an option for people who are below the poverty level or at the poverty level, because of narrow networks, there are plenty of specialists who won't even see kids with Medicaid. Also, I just want to point out here that the Medicaid income eligibility limits for adults varies by state. So again, if you see one program, you see one. And I just want to point out Texas over there, which is, it's not even at the 100% level of the federal poverty limit. It is lower than that you at that point become eligible for Medicaid. Also, our federal poverty limits are established on 1963 data and not 2020. And also, productivity pay, productivity and pay gap has increased so much that you are earning less than you are producing and you don't qualify for Medicaid in Texas, is basically the point of this graph. Now, we talked about Medicare, so there's private health insurance, Medicaid, Medicare, those are the main insurers. And we probably don't have time for this, so we'll probably get more into this in the 4th lecture, but I just want to give you right now some context of later. We'll be talking about what an individual pays into their insurance program. And how, can anyone here tell me the relationship between the scattered plot and the 4 red dots in the upper left? Is there a positive relationship, negative relationship? Any guesses? I'm going to give it to you. There is no relationship. There's an absolutely zero, cuckoo bananas, absolutely zero relationship that you're seeing between any of these plots. So very briefly, what this is that the blue dots represent Medicare spending. Let me just show it like this. So the point is that Medicare is federally funded, federally administered, so it is one insurer. They are one insurer, and therefore they're able to negotiate one price. So that blue line, that's the Medicare reimbursement for a pretty standard procedure, a pretty standard medical service at lower limb MRI. Now, what you'll see in the red is the private insurance reimbursement. So if I live in Columbus, Ohio, I could be spending $2,000 or I could be spending $1,000 for the same service. And it just depends on which plan I'm in, who's representing me, what insurance group I'm in. When I'm in Medicare, that's all under one insurer, one administrator, and they are negotiating for one price, and that is across the country. Versus in Denver, Colorado, if you're on Aetna, versus in Houston, Texas, when you're in Aetna, you could be paying $4,000 or you can be paying $1,000. And that is the price of the health service. So the point of this is to kind of reflect the idea of the complete lack of transparency of pricing, because there's so much variability and it is a function of the different players who are able to negotiate different prices. And then the last thing that I just wanted to address was the idea that, so basically there's just some other smaller insurers. We don't have to do this. But one of the things is the idea that when you lose your job, you lose your health insurance. That's unique to the United States because, again, we are the only Western industrialized nation in the entire world that does not have universal health coverage. 43% of Americans, so at least like a little less than half in 2022 were underinsured. So we're either had the insurance label but didn't have an insurance package that actually covered the health service that they needed, or they just didn't have insurance. And the other thing is that debunking a little bit the idea of who is uninsured. Oh yeah, maybe it includes some unemployed people potentially. It also includes plenty of employed people. Most uninsured people are in low-income families and have at least one worker in their family. So if you remember, Medicaid is like really dirt wages are what allow you to get into Medicaid. And so a lot of people are left in that gap where you're low income, but not low income enough to get Medicaid. So this is just to debunk one thing, that it's not just unemployed people are uninsured. The other idea is pre-existing conditions. So one of the things that the ACA tried to do to reform our system, not change it, but to tweak some little policies here and there, was to get more people insured based on their pre-existing conditions and not be excluded from health plans. However, there are still situations in which just because you're on a health plan doesn't mean you'll get a health service that you want. So here are some of the kind of laws about transgender and gender affirming care in Texas and how you can still be denied certain types of medical services. And the other thing is that while undocumented immigrants are represented in this group, plenty of documented immigrants fall in this uninsured group. 1 in 5 adults in immigrant families with children report that they or a family member avoided a public benefit like SNAP, Medicaid, CHIP, or housing subsidies in 2019 for risk of their green card status. 10% of those without children avoided such a program. So this is just to say that in families with mixed family status, when you qualify for, just because you qualify for benefits doesn't mean that you access it and doesn't mean that you benefit from it. And with that, there are plenty of other resources that we can go over, but I do want to give Dr. Weisbart some time. I would really appreciate it if all of you could please take your phones out and look at this QR code. It's not the sign-in, it's the feedback sheet, and this is for after. But I would love to see all of you take out your phones. And whether you disagree with what I'm saying, whether you agree, whether you hate it, or you love it, I really love your feedback, because part of what the point of this is as well is that it's not just to brainwash you to think that what I'm thinking, but I think that open discussion, open discourse, feeling informed and therefore informing your opinion and having an opinion is a really important piece that we need if we want anything to change in our health system. And with that, I'm going to check on Dr. Weisbart. So the sign-in form is in the Zoom chat in case any of you on Zoom need it. And we also have 2 physical copies up here. And then this is the feedback form one. So if all of you could, again, just make sure that you fill that out, and y'all on Zoom too. And also Zoom chat if there's any issues with filling that. The feedback form now, or? So I'm being asked if I should fill out the feedback form now or at the end. If you do it at the end. Yes. I'm going to run out. So I was asked to pass around, and I will. And Dr. Weisbart, whenever you are ready, we can go ahead.
Hi, folks. I believe I can see y'all. So can you see me? Yep. Head shakes, something. Hello. You all are there, right?
So sorry, Dr. Weisbart, you're just
Someone chime in. Let me know if you, yeah, okay, good. Thank you. So thanks, Yosha, for inviting me. That was a lot of terrific information. So I'm pretty impressed with how you pulled that all together. So I'm Ed Weisbart. I'm a family physician in St. Louis, Missouri. I am really delighted to talk to you about this topic today. I remember when I was at your point in my training, somebody from what was to become PNHP. Wait, there's a message here that I need to, I guess, figure out. We're going to figure out the audio. So, okay, I will pause. I'm being asked to pause.
I'm going to. I don't know why. Is there? Okay.
Can you hear me, Dr. Weisbart?
I can.
Okay.
Can you hear
we had to
me?
change rooms last minute. Yeah. So we were just figuring out the audio.
Okay. I'll have a sip of my wonderful tea.
If not, I'm wondering, should we just turn the laptop?
Because whoever's in business connected, but it's not. You know what we could do? Okay, let's mute this. And then. Okay. All right, Dr. Weisbart, can you say something? Can you hear us? No. You can't hear us. Okay, lovely.
You don't want to create like, no, so it's like. Also, he will be.
Okay, can you hear me now? I guess you didn't know, but I have a part-time job working for Verizon, so that's my catchphrase. Can you hear me? I'll take that as a no. Can you hear me now?
Okay.
I could take out my ukulele and try playing a song, but
Better?
that
Yeah, we
doesn't
can hear
sound-
you now.
You can hear me now.
Yes.
Okay.
Oh, maybe
Okay.
Great.
Should I proceed?
Yes.
Okay. Okay, I should start. Okay. See, this is why semaphore was invented. Predates Zoom. So I'm glad to be invited into a chance to talk with you all. I guess in the interest of time, we'll sort of cut to it. Let me give you a little screen share here, show you what I'm talking about. I believe you can see my slides now, yes? I will assume, yes, that's it. Oh, good. I like that. See, semaphore, it's an underrated thing. So we'll spend the next little bit of time sort of unpacking some of the things that you heard so clearly described by Yosha. We'll unpack a little bit of it and explain what this would mean. What is single payer Medicare for all? And true disclosure, I don't care about this topic. What I care about is all the people that I've met in practice or family or friends who can't afford healthcare, who take their insulin every 3 days, even though they're barreling towards end-stage renal disease. Those are the folks who can't get their asthma inhaler. Those are the folks. That's what I care about. But I want to talk about this with you, single payer Medicare for all, because I believe this to be the most sensible, evidence-based, simple solution to the problems that really light a fire in my shoes, and I imagine in yours. Certainly, when you start getting heavily into the clinic, it will, if it doesn't already. So, I will sort of lay out for you a bit about how healthcare works in the United States, sort of differentiating Medicare from some other options that we have. I'll unpack a bit about why I think this is the most sensible solution and such. And then we'll spend sort of the back chunk of time talking about why it matters. It matters to you personally as a humanoid, but why it also should matter to you for the future of your career and your practice. So that's kind of what I was expecting to talk about. But I wanted to start maybe by introducing you to an old friend of mine, a guy named John O'Rear, who lives in a little outside of our state capital. It's sort of a rural part of Missouri. He worked as a as an insurance broker, an insurance agent, carried multiple different insurance companies, and he personally had what he thought of to be the best insurance for his overall health and his conditions and his price and all that. He was pretty proud of that until at age 64 and a half, 6 months shy of Medicare, at age 64 and a half, he developed esophageal cancer. And he spent the next 6 months straddled by an insurance provider that wouldn't allow him to go to any of the terrific tertiary care centers we have in Missouri. He had picked an insurance product that didn't include that because he was indestructible. And so he went to a place that he and I both thought was really not being very aggressive or paying much attention to what he so desperately needed. And I don't know if you've run into this yet, but esophageal cancer is one of those beat the clock diagnoses. It's one of those diagnoses where it's really dismal outlook unless you can catch it early enough and intervene really aggressively. And there was sort of a chance when he was 64 and a half, but by the time he turned 65 and got into Medicare, it was, much more grim outlook. And indeed, when he turned 65, I remember what he said was, it's like he now has, it was his phrase, that he has the keys to the kingdom. That was how he described it, because he could finally go anywhere. And we got him when he was 65 years and a day. We got him connected with the oncologists at Washington University, where I was volunteering. And it was pretty far gone. And my buddy here, Lefty, passed away a couple of months after that. So turns out he was very unusual, but he wasn't unusual in the sense of his access to healthcare. He made the kind of seemingly prudent decisions that most folks make. I'm healthy. Why should I pay for such and such when I'll deal with that? Well, you can't always deal with that when you need to, and it's absurd to put people in that situation. And more than absurd, it's actually pretty dangerous. Here's I think this is my wonkiest chart, but y'all are med students. You can handle this wonkiosity. This chart is any of my charts that have data on them, as this one does. There's a footnote in the bottom left-hand corner, which I can read to you if you really need to know my source. But they're all public domain, peer-reviewed kinds of sources. So this chart tracks 30 high-income countries over the course of 50 years. So each one of those lines is one country individually. And you can see that over that 50-year period, until we hit into COVID, where this data is going to look quite different next time it's collected. But up until then, what you saw is that every one of these countries gradually had increasing life expectancy, sort of a steady climb on that, coupled, of course, with a steady increase in what they spend per person on healthcare. So the good news is that y'all are in the right place. It seems as the countries spend more on healthcare in general. It's associated with what you can argue is the most important improvement in health outcomes. So it's a trick slide though, because the question I want to ask you is which one of these colored lines is the United States? And you probably already know that we're not on that chart. We're our own little line all the way over. So the first thing to notice about that is, oh my God, we don't want to be like that. But really the first thing to notice is that back at the beginning of this data set, we were kind of in the middle of the pack. We were spending more or less what other countries were spending, and our life expectancies were more or less other countries. But over the past 50 years, we've gotten way away, so that now we're spending roughly double any other modern nation, and we're living 3, 4, 5 years shorter. Our lives are being cut short compared to what they get. So what's the difference? If you look at those 30 countries versus us, the most glaring difference, and there are probably others, but the most glaring difference is how they choose to organize their health insurance. My friend Lefty O'Rear, whom I told you about, he wouldn't have had the problem he had if he still would have had cancer, but he would have not had to deal with narrow networks of which hospital and doctors he can go to. And all of these other countries, they all organize healthcare differently. So they're not by any means the same, each one, but every one of them guarantees affordable, unfettered access to healthcare, to health insurance. And then here we are, clearly absent that, but we've not been sitting here idly. We've tried a whole bunch of different things. And indeed, you can make the argument that where we started to flip away from the curve was when we veered away from attempting national health insurance and towards managed care. So the HMO Act and I know some of those things I put in little red boxes. You don't know all of them probably, but what they all share in common is the introduction of a financial intermediary who has an opportunity to make money off of healthcare rather than being incredibly focused on the long-term health outcomes that a national health insurance program is designed to reward. So we're different from all those. How is it set up here? Well, here's my little cartoon brain. It says there's all of us on the left, and then there's the stuff we want, doctors, hospitals, and everything else on the right. And in between us, of course, is the money. And we've imposed or interposed payers. And that's the United States government is a payer. They pay for that. We pay taxes. They pay for the healthcare for the Department of Defense and for most of Medicare and such. Then there's the flag of Missouri and the flag of Missouri. It's both of them. There's the flag of where I live. So states pay for roughly half of Medicaid, and they pay for the school teachers usually, and state employees, schools. That's the University of Missouri. There's another. Sorry, that was the city of St. Louis, and they pay for healthcare. There's school, businesses, insurance companies. So we have this complicated gamish called a multi-payer room, or multi-payer solution. Nobody else does it like that. It's complicated. So if you think of it, that means in one way or another, we pay each of them. So we have this complicated arrangement of payments, and then they, on the other side of that, have their own contracts with each doctor and every hospital and pharmacy and stuff. So it's complicated, and it's even one more level complicated in that the payers decide, well, we like this doctor and not that doctor, and they're all different, so really complicated, really expensive to maintain that complexity, and it's just needless. But it is not just bewildering, it is expensive. Here's us on the bottom there spending roughly double every other country. But what's not, and that's, I think, pretty well recognized at this point, what's not as well recognized is if you just look at public versus private. So the public dollars here on the green section, that's the obvious part. That's what the federal government pays for the military and the states. That's the obvious tax dollars. It's also the reason you don't see this very often is that this calculation also includes, well, if a business gets a tax break for paying for employee health care, well, that's lost revenue. So that's really also public funding that we've diverted to it. So if you add all that up, our public dollars in the United States, just the public dollars, is more money per person than other countries spend in total. Remember, and they have universal health care and better outcomes and live longer, and we don't have that. And then add on top of that another $4,000 of what we pay out of pocket and through our employers and such. So we're, it's bewildering and it's expensive. And the thing that we ask of our commercial insurance industry, is to be efficient and to be effective. Well, here's the overhead, just the overhead of the insurance industry. This is SEC filings. This is their overhead. And then here's the overhead of traditional Medicare. So I use the phrase traditional Medicare. You may have also heard the phrase original Medicare. Those are synonyms, so don't try to figure out the difference. They're synonyms. And what they refer to is Medicare Parts A and B. Medicare Part A, as you know, is hospital. Part B is primarily office-based stuff. So Parts A and B, that's separate and distinct from Medicare Advantage, which we won't get much into today. That's Medicare Part C, but it's a commercial version of Medicare. But if you just look at good old-fashioned traditional Medicare, the reported overhead is 2%, and the commercial industry is dramatically higher at 15%, let's say. It's not magic how traditional Medicare is so much more effective at use of their resources. It's because they don't have to do things. They don't advertise on the television machines, right? You turn 65 and you just about automatically get Medicare without having to see an ad on TV. There's all kinds of efficiencies built into traditional Medicare that the other insurance companies simply can't possibly match. And this overhead is the smaller part of how we waste money on the way we've set up our healthcare. The typical doctor in practice spends about $100,000 per year on staff who work hard and have as their only function interfacing with the insurance industry. So your fee schedule or your salary has to be inflated adequately to make up the payments for $100,000 worth of staff to interface with the insurance industry. In Canada, it's more like $20,000 or $25,000. So that's just, expensive. And then hospitals, I think the next slide is about hospitals. No, it's not, sorry. Hospitals are even more outrageous, where we have 900,000 hospital beds in the United States and nearly 900,000 hospital employees working in billing and insurance functions. So 900,000 beds, 900,000 billing and insurance staff for hospitals. So every hospital could put somebody from billing at the foot of their bed, just about, not physicians, but billing staff. And in Canada, Toronto General has roughly 900 beds and has 7 billing people, whereas Duke University has roughly 700 beds and it has 1,200 beds and has 1,600 billing people. 1,600. So, it's crazy how much we spend on propping up the insurance industry. So why talk about Medicare? Is it really much better than commercial insurance? Well, there's 3 things. I know you know some things about Medicare already, but there are 3 things that are not, I think, widely enough recognized. The first is how many fewer barriers there are to care in Medicare compared to Medicare Advantage or commercial insurance. So we all have to live day in and day out with prior authorizations and with all kinds of things that get in the way of healthcare. Those happen all over the place in commercial insurance, Blue Cross, United, and such. They happen in Medicare Advantage, which, as I said, is the commercial insurance industry invading Medicare. But traditional Medicare, they don't do that. They've got like 5, I think, things that they prior authorize, relatively obscure things. So traditional Medicare has very few barriers to care, and I'll show you a little bit more about their networks. It's amazing. It's incredibly lean and efficient, and actually has an impact on our life expectancy. So I want to unpack those things a little bit more. In terms of national networks, so if you ask physicians, which Kaiser Family Foundation did last summer, do you accept Medicare as a payment? Non-pediatric office-based physicians, 90%. 90%, almost every non-pediatric office-based physician says, yeah, I take Medicare. Now, it's a smaller percentage who accept new patients with Medicare, because it's a smaller percentage who accept new patients with anything, but 90% have Medicare embedded in their revenue stream. And when I look at surgical specialists, it's pretty darn close to 100%. So with Medicare, if you're living in Austin and you take vacation to California, any doctor you want to go to in California is probably still in network. Whereas if you have insurance from, I don't know what insurance that you all have as med students at Dell, but if you chances are your medical insurance, chances are, doesn't cover you for anything but an emergency if you're outside of the region that your insurance company works primarily in. So with Medicare, that's not an issue. This is 90% of doctors in the entire United States. There is no other insurance company that's like that. It's also remarkably effective at the main thing that we claim is the reason we want insurance, which is to control the cost. So here's 10 years worth of data looking at how well the insurance companies have controlled cost. Commercial insurance companies have seen more than a 50% increase in per person spending during this 10-year period. More than 50%, way higher than inflation in the country. Is that good, bad? Well, Medicare has kept it inflation rate to less than half of that. And that's Medicare all rolled up, traditional and Medicare Advantage. I don't have data that breaks those two apart, but I imagine if you just look at traditional Medicare, it'd be even more striking how effective it is. And then lastly, and most importantly, some data that you saw from Yosha, but I just want to underscore a little bit. It makes us healthier. So this is from the Institute of Medicine, looking at our actually mortality rate, but I think of it as life expectancy, compared to 17 peer nations stratified by age. So there's a list of the countries at the bottom if you really need to know: Australia, Austria, Canada, Denmark. There's a list there. And you already know, number one, because you knew before you came in, number two, because Yosha showed you, number three, because I'm going to beat it into the ground. You already know that we're going to be at the bottom of this chart, because, you know, our life expectancies are 3 or more years shorter. So here we are, stratified by age, with kids on the left and seniors all the way to the right. And there we are, merrily holding up the bottom of the chart, worst mortality rate or perhaps life expectancy, but by every age, until the magic happens and we turn 65. According to the Institute of Medicine, once we turn 65, country by country and year by year, we climb to literally the best in the world. So this is a second reason to think, hooray, you're in the right place, going to med school in the United States. We have the United States has many of the world's best doctors and hospitals and pharmacists and such. We must, or we couldn't possibly have this kind of a curve. The challenge is we just don't let everybody into our healthcare system. So that's why this is such an incredibly dreadful slide. There's nothing but cracks in this system, gaps. And what we're proposing is that we get rid of all of that, frankly, and replace all of those multiple payers. Now you know what a payer is. Replace all of those multiple payers with one payer, a single payer. And we believe building it based on Medicare and improving Medicare is the way to do that. So what does this mean? Single payer Medicare for all. It's pretty simple, really. First thing means improving Medicare. Medicare is far from perfect today. So have it cover all the things that are medically necessary. There's not much disagreement that everybody should have access to a dentist, you know, or hearing aids. So all medically necessary care, not all of which is in Medicare today, but all of which needs to be in an improved system. Get rid of the copays and deductibles and premiums. You know, Yosha really unpacked that nicely about how that's regressive, and it just means, you know, so we think we should design a system without copays or deductibles or premiums, just fund it equitably through the progressive tax system. If you did these things, then you wouldn't have to learn the arcane information about Medigap or Medicare supplements or any of that stuff. That the market or Medicare Advantage, that stuff would go away because you wouldn't have to even outlaw it. There would be no market for it because everybody in the country would already have things. And so if you did all that, then the answer is you would fund it in an equitable basis, you know, more based on income, you know, a progressive income tax system. And then the last thing about improving Medicare is that it's incredibly, we've allowed Medicare to develop some fairly complicated reimbursement models for physicians. And there's really virtually no evidence that that's improving outcomes or clinical care processes. So we think there's a huge opportunity and need to simplify the way physicians are reimbursed under the improved Medicare model. And then the second thing is don't leave anybody out, you know, cover everybody who lives here, you know, regardless of age, you know, regardless of income. If wealthy people and low income people are in the same system, then it's a lot more mainstream and less likely to get marginalized. It means cover from cradle to grave, obviously. This idea of pre-existing conditions disappears. And if you think about it, I mentioned that 89% of physicians today in adult medicine practices accept Medicare as a payment. So nobody requires physicians to accept Medicare as a payment, and indeed 11% do not accept it. And nobody would require a physician to accept payment under Medicare for all. We put in the programs exactly as proposed and written, and a physician can still say, I'm not playing, you know, I don't care. You want to see me, I'm not taking that as a payment. You got to pay me full retail. So there would be some who would do that. It would be a smaller number than the 11% who do that today, because anybody who says they don't want to take it as a payment would be having to want to and be able to tell literally everybody who lives in their community, I know you have this insurance that's progressively tax funded that should cover every doctor you want, but, you know, and you're still going to have that. You can't, you know, you're still going to have that. But if you want to see me, here's my retail price, right? So there would be some doctors who would want to do that, who would be able to do that, who would do that, but it would be a smaller number than the number who today don't accept Medicare. So pretty much patients could pick the doctor that they think is the doctor that they want in the hospital that they want. I won't spend much time on this. Yosha did unpack this. The economics are compelling. And just to know that the Congressional Budget Office has said, absolutely, we can afford to do this in the way that we're talking about it. So why do doctors want it? And I would argue that it's because we're just sick and tired of having people not able to get the care we recommend. You know, we do the hard work, we figure out what's going on, we give the patient our best advice, and we negotiate that with them, and then they come back later and say, hey, I couldn't take that insulin, or hey, I couldn't get that test, or they, you know, and it's just, when this repeats over and over again, it's really demoralizing. And I submit to you that that's one of the biggest problems driving burnout. And indeed, the data shows that we are among the least satisfied with medical practice in the world. So that's the good news. Huh? And here's sort of one good metric of that. I'm not sure what electronic health record you all use there, but Epic is a very common electronic medical record. I've lived through two hospital implementations of Epic in my happy little life here, and it's just software, right? It's an app, and so you can set it up with switches that do this or don't do this, that do that or don't do that. So Epic at one hospital is a little bit different from Epic at another hospital. It's customized to meet the needs of the hospital that it's in, and it's actually used all around the world. So here's an interesting study that was in the Annals of Internal Medicine 5 years ago that looked at the number of characters that people have typed in to a progress note in Epic. The average number of characters in a progress note, an ambulatory progress note in Epic, and around the world. And it turns out that in most countries, Canada, United Kingdom, Australia, the average is around 1,000 characters per progress note. Whereas in the United States, with no overlap, interestingly, in the United States, the average is 4,000 characters. So when you're in clinic around the ward and making a progress note, if you feel like 3/4 of what you're doing isn't adding clinical value, that's because 3/4 of what you're doing isn't adding clinical value. It's medical legal risk aversion, which, you know, the reason to sue you plummets under Medicare for All, and it's optimizing your billing, which again, we can design a better system so that would improve. Malpractice, just to touch on that, is indeed nowhere near as much of an issue in other countries where the cost of healthcare is part of what you're going to have. You don't have to sue somebody to get your healthcare paid for after you've had a bad outcome. And then lastly, income in Canada is pretty comparable to income in the United States. In some cases, better if you look at this, specialty by specialty. And this is converted to US dollars, usually using 0.75 as the conversion factor. So big difference. If you just look at what it's like to practice, last thing, if you asked the president of the American Academy of Family Physicians, speaking as a family doc, he recently said it's an incredible mess to get anything done for patients. Whereas his equivalent, perhaps in British Columbia, says, no, not a big deal. I can focus on patient issues, not administration. So, I mean, way better life, preserved income, better health outcomes. I mean, why the heck wouldn't we, be jumping on board with that? And so that's why I spend almost all of my time as a volunteer with Physicians for a National Health Program, pnhp.org. So, we're nonprofit, nonpartisan, most of us who are members actually pay for the organization to exist. We don't have this big conflict of interest or grants, nothing that's conflicted. We just want to get the right thing done. We have a really exciting student growth among students. They call themselves Students for a National Health Program, or SNAP, the name they came up with, and it's free to join. Just go to SNAP or, student.pnhp.org, and I'm sure Yosha will be glad to tell you more about that. So hopefully we have some time I need to pause for just a moment. Okay.
I just, in the interim, while things are running, figured out what I'm doing. Yeah, okay. Dr. Weber, thank you so much for all your, just like amazing evidence base, and kind of like you said, the reason why you're here today, and I'd like to offer the reason why I'm here today, is not because I love single care. I agree with single care. I think it is the way to move forward, but I'm here because of all the patients that I saw across the street who weren't able to access health services that they deserve. And so in spirit of that, I'm sure all of us have either our own health kind of issues, or, you know, people who we love, and that's why we're here, or we care about health. And so from that angle, I'm curious, anyone has any comments, questions? If you want to put it in the chat, then you can put it and I'll say it into the speaker. Or I will come to you physically in the audience if you'd like to say. Okay. Yeah, I'll come to you.
Hi, I had a question about what you think the benefit of some tweets of the no water might be. Since we talked
I can't hear you.
especially misinformation was known. So
She can't hear you.
I got nothing.
Can you hear me, Dr. Weisbart?
I can hear you.
Just
Okay.
talk closer to the mic and louder.
okay. What is, I guess, the significance or usefulness of tweets like Dr. Wendell Potter's that we learned about in this lecture? If we also learn that community organizing is a stronger method, and Twitter can be full of misinformation.
Dr. Weisbart, did you hear that, and or would you
Yeah,
like to
no,
respond?
Yeah, if you could repeat the question,
So I'm just going to repeat
sorry.
your question to the Zoom audience. So basically, we got the question of what is the utility of something like Wendell Potter, or even in general making tweets, going to social media, versus the power of community organizing, and how that might be a quote unquote better method for organizing. I can respond to that, say that I kind of have two responses. One is that to kind of differentiate between advocacy and organizing. And so advocacy is very much like a transactional kind of thing. You can go advocate at the legislative session that's happening in Texas right now. You can write a little tweet, you can talk to your neighbor, you can do all of that, and that is one form of advocacy. And I would say in contrast to that, organizing is about building power. It's about building collective power to be able to bargain for your need against whatever decision maker has kind of gate-kept that resource. And so kind of what SNAP, the Students for a National Health Plan, in conjunction with PNHP and other single-payer advocates are trying to do is organize together as a collective that is in solidarity and demands from insurance agencies, the government, all of that, a type of better system. So that's not an answer to your question. That was the first thing. And the second thing is that I imagine, I mean, I'm not the expert on this, but I would say, I imagine there's some level of utility of like reading a tweet. I know that when I was like an adolescent, when I was in high school and stuff, I would read stuff online, and that was kind of how I first started engaging. I think that there are plenty of actors in the media space who provide the opposite standpoint, and you know, like to that degree, it's important to be in the public space and be offering your takes or your opinions or things like that online. But I would just say that's not the end all. And so even just having the evidence is here. Dr. Weisbart, you know, presented really well about that. There are plenty of resources that I'll give out via email once I have everyone's emails. But the evidence alone is not going to get us there. The tweeting alone is not going to get us there. And again, part of what this lecture series is about is how do you actually build collective power? I hope that answers your question. Are there any other questions? Yeah, I'm going to bring you up. This is a funky, okay, yes.
Hi, yeah. So throughout this whole series, I guess just coming from my perspective, like I lived in Canada for a couple of years and I'm for the single payer system, but I recently read a book that was really interesting by Sean Flynn, an economist at UC Berkeley, and he kind of proposed his own take called The Cure That Works, and he kind of looked at Singapore's healthcare system and how they did have a nationalized system, but it was like the CDHP plan and like a nationalized HSA, and he kind of he made the argument that like the patient and like really everyone involved had like a cost benefit analysis. And I was just more curious, like getting to that single payer system similar to Canada is like a huge, it's going to take a really long time. And I was wondering, do you see like a bridge like system similar to that before we get there? Or do you think the biggest thing is just to get to the single payer system period?
Yeah, that's a
Turn the
good,
speaker on there and then put the mic to the speaker. And then
what? I missed that last comment. I don't know what that, I heard the question, but I didn't hear what, I don't know what you said. I don't know what you said. I'm just going to answer the question. Okay, a good thumbs up. Okay, so if I can remember it now. A couple things. First thing is, I don't know how long it's going to be till we get to single payer, and none of us do. I can tell you that it always looks like it's way off into the unachievable future. Always. Every major social change looks like it's impossible, that the financial vested interests, that the complicated political landscape, every major social change looks impossible, even as recent as 2 years before it's accomplished. And then within 2 years, it's historically accomplished. It's done. But think of any major social change, and that's true for. Now, I'm have a really high level of confidence that it's not going to happen during the remainder of President Biden's term, and I don't know what's coming after that. So who knows? But so we are at this, at this point. Yeah, I think that it's fair to say we're not at the 2-year trigger point for that. And frankly, instead, right now, I think the focal point needs to remain on building understanding of what single payer is, dispensing some of the myths about what the inflammatory. You mentioned Wendell Potter, the last questioner did. Wendell uses the term of FUD. It's a marketing term: fear, uncertainty, and doubt. So one of our jobs is to dispense with that. So we need to keep on that direction, or whether it's off, but more importantly for the next 2 to 5 years is, if we do want to build a system based on Medicare, well, Medicare itself is under direct frontal assault constantly. Medicare Advantage, which is not Medicare, and it's not an advantage, it's just commercial profiteers, frankly, able to charge Medicare more and give less health outcomes. And amazingly, because of how good the television ads are and other things, Medicare Advantage is now half of people in Medicare are in this commercial nonsense. So Medicare Advantage is corroding Medicare, and there's a parallel similar attack on the rest of Medicare. So the mission for the next 2 to 5 years, I think, for people who want to get to Medicare for all, is to protect, defend Medicare. And there's a whole bunch of specific strategies that PNHP is probably beyond the scope for today, but there's a bunch of specific things of what that means when I say that. In terms of other transitional programs, like, should we do something like Singapore, based on HSAs essentially, or should we, introduce a public option? I always come back to the notion of, well, does this get us closer in, or does it not? Or if we fight for one of these transitional plans, so let's take any one of them. Let's take the Singapore model. If we fight for the Singapore model, we will spend, let's say, 5 years fighting to get that to happen. And once that happens, it'll then take another 2 or 3 years to implement it. And then it'll take another 3 to 5 years to analyze what that accomplished. So if we put our energy behind fighting for, advocating for something something like that, we will have delayed by 10 to 15 years the fight for what we need. And then our divergence from all those other countries, Singapore, I think, was one of them. Our divergence from all those other countries will be wider. Our outcomes will be worse. Countless, people, more people will have died. So if we thought that the Singapore model was a better model, or any of these models was a better model than the model that we're proposing of a single payer Medicare for all, if we thought that was a better solution, then I would say, well, let's not think of it as a bridge. Let's think of that as the solution and put our fight behind it. But it's not. And the main reason I would say it's not is it addresses a problem that we don't have. You know, the idea of HSAs and getting more skin in the game, the core philosophy of that is based on the premise that people are just using too darn much healthcare in the United States. That the problem with healthcare in the United States, the reason we spend so much is because people just can't wait to go get that colonoscopy, or they can't wait to get that whatever it is, and we're using too much. And so if they had more of the financial risk of that decision, the HSA model proposes, if we had more individual personal financial visibility into the cost, you know, transparency, you know, if we just fixed that part of it, then people would make their own more prudent decisions. And what we know is none of those promises are true, right? We know that in the United States, even insured people, fully insured people in the United States, use less healthcare services per person than the rest of the countries that we've been talking about. They use fewer services. The reason healthcare is so expensive here and so unaffordable, it's not really complicated. It's because we pay too much. The prices are crazy high. And that's not because doctors are getting filthy rich. That's not what that means. It means because for you to just be in business, you have $100,000 worth of office staff that you have to pay to deal with the insurance industry that no other country deals with. And so the fee schedules for Medicare and for all of the insurance payers has to be propped up enough so that you can do that. You know, pharma can set their own prices. We don't get to negotiate drug prices. Maybe that'll change. Maybe it's starting to change. Well, a long way to go on that. But basically the problem is the prices are too high. Prices are too high. And we don't want to change physician income. And indeed, none of the models that we've looked at, I've showed you a list of 30 sort of, including the CBO's really robust analysis. None of those models assume any decrement in physician income. So we don't need to change physician income. We obviously need to pay hospitals enough so that they can thrive and survive because we need them. We need to fix the infrastructure that demands that we pay so much. So I don't see that going towards an HSA model as being something we should put much advocacy work into. Does that address what you were asking? A long answer to a pretty short question. And you're on mute. You're on mute. I have no hope of hearing you.
Hello.
There we go.
Yes. And then should I keep this on? No, should I keep this on? Yes.
Keep it on. Yes. Okay. Yes, he said yes. Thank you.
Good question.
I just want to respect everyone's time. So thank you so much for being here. Please fill out the feedback form. We really want to hear from all of you, and a big round of applause. And thank you to Dr. Weisbart for being here today. And with that, please come again in 2 weeks.